as a drug discovery and the development for Zika viral diseases. Yeah, that is your project. So because here we are in the faculty of the pharmacy of the university. So let me to present you Gvantsa Chanturia. Yeah, Gvantsa Chanturia. She is a virusologist or virologist and molecular biologist. Is very experimental person in this field. I will talk in Romanian because for the people, yeah. Gvantsa Chanturia este un virusolog și un biolog molecular experimentat cu un palmares remarcabil în contribuții în cercetarea în domeniul sănătății publice și managementul proiectelor. Deci, dedicarea sa este setul extins de competențe și colaborare internațională, care au făcut-o ca o figură respectată în domeniu, determinând progres în domeniul virusologiei și epidemiologiei în Georgia și la nivel internațional. Deci, actualmente, dumneaei conduce un proiect de anvergură ce ține de febra hemoragică Crimea Congo în Azerbaijan, dar totodată este șefa departamentului de virusologie a Centrului de Cercetări în domeniul sănătății publice a Georgiei. Doamna ne va prezenta deci titlul cu prezentare, titlul este The Role of Early Detection, Characterization and Tracking in Public Health Emergencies. Please.
Thank you. Okay, that's me without mask there. Okay. I apologize for having lecture in these conditions with the mask, but I'll try to do my best. I hope you hear me. Okay. I work at the National Center for Disease Control and Public Health, actually, which is the central public health organization in the country, under Ministry of Health of Georgia. Sorry? Okay, I have to bend this better. Okay. I'll try. No, it's okay. Okay, so our center was established as an anti-plague center in 1937, but since that time, actually, in 1996, it was re-established. Okay. It was re-established as on a model of the US CDC in 1996 and became National Center for Disease Control. And later it integrated also the medical statistics department as well as the public health. And in 2013, actually, the Lugar Center, which was built by DITRA effort, was also integrated into the institution. Okay, this is a structure. I will stop on this, and there's the different directions we work on. Okay, this slide shows the map of different public health and veterinary laboratories throughout the countries. There are local laboratory stations and the public health stations that do just very basic laboratory. There are several zonal diagnostic labs that do more complicated ones, like including molecular biology detection. And our center, Lugar Center, is located in Tbilisi, in the center, and it represents a reference center for other stations. This is actually a list of our partner organizations. We have a lot of collaboration and the funding from DITRA, WHO, CDC Atlanta, Rotary, and many other UN organizations and other institutions and universities as well. Okay, so So about the Luger Center, we have a BSL 2 and BSL 3 facility, laboratories, and we are actually responsible to participate in detection. The main function is to detect the special dangerous and other pathogens as well, and to characterize them, also to participate in all of that, and do the zoonotological surveillance, have a biomedical research potential, and provide trainings for universities, for other countries as well. And we have an NGS capacity with 2 MySics and NextSic, which we plan to improve either, and 1 nanopore as well. And we also started recently to provide quality control for other organizations, and we're talking about that later. Okay, so I would like to talk about 2 efforts which were conducted with the help of CDC in Georgia. This is hepatitis C elimination program, which was started in 2015. It was under support of CDC a lot, and US government. And first what we had to do, and actually it goes to treat all the sick with hepatitis C people. But for that you had to know approximately how much sick people you have in the country. So for that you had to have a seroprevalence study done. Which means that we had to test random population and have an idea of what is the percentage of RNA positive in the country. So in 2015 it was done, I don't know, oh okay, mouse works. So in 2015 when we did it, so we had about 7.7% of prevalence, serology positives in countries, and 5.4 of RNA positives, quite high. And actually this seroprevalence was supported by CDC, and CDC sent a Moldavian person who works in CDC for 20 years, more than I think. This is Jean Ravenuk, he's there on the picture with us. And on the back you can see this board where we wrote down all the efforts we had to do in seroprevalence, because we were the only ones who had to do it. And that's the result actually, and actually when the program was started there was a lot of effort of treatment, of engaging people and everything, and when we repeated this seroprevalence in 2021, you can see that actually the RNA positivity was 1.2, it's highly decreased. And it's not just a treatment, it's also preventive measures done in countries that you shouldn't get sick again. I mean, because there could be also reinfection in hepatitis C, you can get it again at some point. And this is also distribution of the different genotypes as well. And but the main thing is that when the program started itself, we needed a lot of laboratories who would test people and they see if they are positive, they need treatment, and if the treatment worked also afterwards, right? And therefore we had to involve a lot of laboratories because we couldn't do it for the whole country. And then we had to control how it is performed. And for that, we had another Moldavian for help here, Radu Kojakaru, who is still our good friend already, and both are here now. Actually, we started a QA program for the country, for the laboratories that were involved. The PT program, again with the CDC Atlanta. Okay, PT panels were made. Actually, we had from blood transfusion centers, we get these bags of positive and negative also samples. We did the dilutions, distribution, and like in big volumes, and then aliquoting, storage, and then retesting and everything. And those panels were distributed 3 times per year to all laboratories that were involved in the program while they were involved. Actually, at the moment, this PT is more or less stopped. But it is continued with the combined PT with the hepatitis C, B, and HIV with the blood safety program. Okay, this is one slide of hepatitis C genetic characterization, the GHOST technology, which was developed by CDC team Atlanta, was also implemented at our center. And it actually what does you actually sequence, you amplify the hypervariable region of hepatitis C, which actually changes a lot. And as you know, hepatitis C can persist in the organism for a long time. I mean, for years, for decades sometimes, before you know that it's doing something with you. It can be latent. So during that time, the virus changes in the body. It means that more time you have the virus, more quasi-species you have, more variants of the virus you have inside. And with this sequence, what you have, so in this hypervariable region, you have, you can get all these subvariants you have, and it shows you like that more, longer you have it, like a bigger ball of the data you get at the end. And it also can track the transmission from person to person, which is actually a great tool. And now they're working also on B hepatitis for the same technology, but for C it is already established. And this is like just the data that we got from one cluster from harm reduction centers, which is actually mainly drug users, and there we could actually find this transmission chains. We had the 2-3 clusters together. And this is different colors, are the different subvariants and the genotypes of hepatitis C inside. So that's also wanted to mention. Okay, and I want to go back again to the respiratory diseases. We have actually influenza respiratory virus laboratory at the CDC, which was established 2006, the national lab, and recognized by WHO. And they perform sentinel, since that time they perform the sentinel-based surveillance throughout the country in several representative places. And they test them all for 21 different respiratory viruses. Sorry. And now also for SARS-CoV. But what means that, and this is data from the last year, for instance, 2022, with the different viruses you have, how many were tested and how many results we got for different ones. It's RSV, Rhino, Adeno, different parainfluenza viruses, and others as well. And of course, influenza. So when COVID came, we already had this network established, which was helpful, but still, of course, we had the issues of dealing with the number of the tests we had to perform, because this is like the first year of pandemic, and we actually started to enter into the seriously pandemic like from the September 2020, because before that we could manage with the lockdowns and the tracking of each sample, we could manage actually very, very low amount of the cases, but from September, October 2020 we had already bedtime, so as everyone I guess. Then actually, and we hit about 5,000 during the Delta prevalence, but when Omicron entered into the end of 2021 and 22, we hit 20,000 cases per day in February 22. And well, this is actually the number of the samples that were tested daily through the year, first year especially. And of course we could not do that. And these pictures I put because on the left side you will see Easter, 12 hours, we had an Easter there. And here it's a birthday which is actually in the lab for the girl, because on the 12 o'clock at night they were still in the lab and they congratulated her with the birthday. And we were actually almost living in the lab like until the late night. And not us, because soon actually a lot of different labs were involved, and actually new labs were created. And what this pandemic, I think, brought the good that we have a lot of knowledgeable young people right now who can work independently on molecular diagnostics without a problem. And this is really great. But for that time, still was a lack of personnel, and a lot of like students who came for like internship and to learn how to deal with the pipette. They were already brought into the lab and they started to work. And also biosafety trainings were provided to all of these laboratories, and not only laboratories but healthcare professionals also for hospitals, because we have biosafety officers and the special department who were trained by DITRA and for a long time, and we know how to deal with that, but a lot of people in other organizations don't. So they needed repeated training, so we had an online and on-site trainings a lot for everyone. But at the final stage, so we had about 52 laboratories involved in the testing, and the criteria of the inclusion was its evaluation of infrastructure, equipment, staff, education, and the protocols for biosafety they had it, and the AQA panel again, which again then the experience with hepatitis C was very helpful because we started to produce the PT panels for these laboratories again. So there was the inter-laboratory comparisons and retesting of random samples also, and also the monitoring of laboratories was performed by self-assessment questionnaires and on-site visit. And we also used to have the online visit, like with the cameras, go there and how would you walk, and so that any kind of monitoring was accepted there as well. So the PT panels were prepared, stored, and checked for stability once in a month before sending. And after that was sent, then was feedback and recommendation provided. So these are the results of different lots of PT panel results. And we had a lot of issues identified, of course. So there was quite frequently, especially in the regions, they had a lack of knowledge in molecular biology basics. They could not understand sometimes exactly what they were doing. They do mechanical sometimes things. Always still was there insufficient human resources because people were working in a different laboratories and they were really exhausted, which is also an issue. And usually the management was underestimating the laboratory risks and inadequate evaluation of the resources of the laboratory as well. And sometimes they were procuring also the low sensitivity kits which were used for detection as well. And as a feedback, actually, our team was going on the site and providing more trainings, recommendations. They were monitoring the number of the sample of tests tested according to the equipment they had and the people they had in the laboratory. And of course we had a lot of communication on site, online, and other. And actually it was very helpful. I was also on that kind of a visit once because the communication was made by people who actually work in the laboratories, so they were speaking in the same language and they were, had a lot of trust with each other, and it helped. Okay, and just two quick slides about the genomic surveillance we performed on the SARS-CoV. This is a tool from GSI, you see the pink one shows the our uploaded strains, so we were hit almost with all probable variants during the pandemic, and we catch them and we sequence them and upload it back to GSI. That's it, what it says about. And from 2021, with the high throughput, we're already sequencing 96 well plate design weekly almost sometimes. And in total, we had about 3,500 strains uploaded to GSI. And for now, we have most prevalent XBB 191 variant in Georgia. And we had like a few EG5 and XBC1 strains as well. For the NGS, I would also mention that we also implemented whole genome sequencing approach similar to COVID for influenza as well. So that's it actually. This is just briefly that we are going to expand our AQA program, obtain ISO, and we work with the CDC on the new project. to make the Lucas Center the regional genome NGS training center for countries. Actually, I think we start with Uzbekistan and Kazakhstan, and then Ukraine, and I think Moldova is going to be included in project as well. And this will be with the USCDC and APHL joint project with them. So that's it for now, and thank you very much.
Thank you very much. So, we have here two diplomas for our speakers, and one is for Gvantsa. Is Gvantsa for your second diploma, it's for hotare. Thank you very much. So we are really late of the time. I think our gratitude we should give to our speakers. Thank you very much for nice talks. We really have to leave because they are waiting for us already. Thank you very much.